My name is Carla Nester, and I'm a professor of internal medicine and pediatrics. I practice at the University of Iowa in the Stead Family Children's Hospital. That's my clinical practice. My clinical practice is in complement-mediated kidney diseases, actually. My research program, or what I'm funded to do, if you will, is the acquired forms of complement dysregulation. So that's my basic science experience, or that's what I do from a day-to-day basis. It's an ultra rare disease, and it's actually, unfortunately, it affects children and young adults, frankly. That's the major group that's affected. And more than 50% of these patients will go to end-stage kidney disease within 10 years of diagnosis. So the problem is even further compounded by what happens is when you try to put a new kidney in them, the disease comes right back. And there's even been a more recent publication that says that it comes back in as many as 89% of patients after you put a new kidney. And that's under standard of care. So the current way we treat patients with C3 glomerulopathy or immune complex MPGN is this standard of care, which frankly is not nearly as successful as we need it to be to actually help these patients. If you think about transit to end stage, if I told you that 50% or more are going to end stage in 10 years, that means they're losing about anywhere from 6 to 10 milliliters of function a year, and you only have 80, right? So if you use 6 to 10 a year, okay, so that's the background. Now, when you think about the APPEAR C3G study, what we do is we take that group of patients that's just heading right to end stage, and now we flatten that out. So not only were they losing that roughly 10, according to the APPEAR study, pre-dosing, they were losing about 10 milliliters in that 2-year period. Once they started on drug, they stopped losing kidney function. That is an amazing thing for a glomerular disease physician like myself to see, because that means, in theory, of course, we need more time, but that means, in theory, this group of patients doesn't head towards renal failure, which means they don't need dialysis as a young adult, and they don't need a kidney transplant. So that was, frankly, from a clinician, that's one of the most important pieces, but their primary endpoint in the APPEAR C3G was that of urine protein. So they were actually able to reduce the amount of urine protein in this group of patients up to, it was just over 35% reduction in urine protein compared to those patients that were on placebo within that 12-month period. So that's the 12-month data. So between reduction of urine protein, flattening out of the GFR curve, this is an incredibly important approach, obviously, for this group of patients. Way back in 2011, when we first started using complement therapeutics, we worried about infection, but the APPEAR 12-month data is very encouraging that the infectious risk in this setting is quite fine. We never want to say good about an infectious risk, but it's fine. It's manageable. I am not at all worried about it. If we immunize these patients appropriately, which is covered by the sponsor's recommendations and even by our regulatory agencies or guidance agencies, we can handle these patients. And I find that this is going to be absolutely a safe approach. And with that degree of efficacy, hands down, we'll be using it the second we can. The most next, I'll say, is going to be that they're progressing through their pediatric part of this. The APPEAR C3G trial that reported out their 12-month data was actually all adults, so greater than 18 years of age. They are now enrolling the 12 to 18-year-old, which is critical because, again, this is a disease of young individuals, young adults, but certainly we all have patients, even down to the age of 8, who are affected with this, even younger in some countries. So it is critical that we get that pediatric result. So that's one of the next wonderful things that's happening, but also, frankly, we need regulatory agency approval. So I'm hoping that what's next is FDA approval so that we can begin using this in patients that didn't quite meet inclusion criteria, or, for instance, the study was closed before they could be enrolled.